Thank you to our students. Good afternoon, goeiemiddag, molweni, sanibonani, dumelang. To those who are here in person and online, welcome to the first institutional public lecture of the Faculty of Health Sciences. I am Dr. Muki Mueng. I'll be your program director this afternoon. The title of this institutional public lecture is themed Revolutionizing Global Health, Change for an Equitable Future. At Nelson Mandela University, IPL's institutional public lectures are a tradition of critical public intellectual engagement. The Faculty of Health Sciences has curated this lecture to align with Vision 2030 and the values of our vision, those of excellence, integrity, Ubuntu, justice and equality. The keynote by Prof. Volmink, who's the Executive Director for Equity at the Wellcome Trust, signals our growing collaboration with global health equity leaders. The respondent, who's online, Professor Ndusi, the President and CEO of SAMRC, brings a South African research and clinical excellence perspective. Ladies and gentlemen, welcome. I am not going to be reading the protocol, as the person who is designated to do so will be joining us shortly. Allow me to introduce our acting Vice Chancellor, Professor Andre Kiet, who's our Deputy Vice Chancellor for Engagement and Transformation at Nelson Mandela University. Over to you, Prof.
Hello, everybody. Program Director, Dr. Mueng, our keynote speaker, Prof. Jimmy Volmink, Prof. Busani Ngweni, Director of the Center for Public Policy and African Studies at the University of Johannesburg, will be making the opening remarks, Prof. Ntobeko Ntuse, President and Chief Executive Officer of the South African Medical Research Council, our respondent, Nelson Mandela University Chairperson of Council, Justice Nambita Dambuza and other members of Council, representatives of the national and provincial departments of health, and of course our crucial partners in that particular arena of work, representatives of the various health professional bodies and faculties of health sciences, too numerous to mention, the DVCs and other leadership present, in particular the Executive Dean of the host faculty, Prof. Zuki Zingela, staff and students, honored guests, and those who have joined us online. It is a great pleasure and privilege to welcome you to the Faculty of Health Sciences Institutional Public Lecture themed Revolutionizing Global Health, Change for an Equitable Future. The history of this particular lecture will still be written up somewhere along the lines, but it's great now that we have, at this particular moment, the first of such lectures. Our university consciously strives to be a responsive, embedded university in the service of society, promoting social justice and human rights, in addition to its core missions of learning, teaching, research, and engagement, but also to move forward towards the academic expression and values and ethos of our iconic namesake. The name change from Nelson Mandela Metropolitan University to Nelson Mandela University in 2017 was far more than a branding exercise. It was an opportunity to re-envision the role of the public university, such as ours, is post-colonial South Africa, but also to re-envision a university like ours on the African continent in this particular century. So at the heart of this vision of a public university promoting the public good, which is nowadays also a highly contested term, is the significance of engagement alongside the traditional work of the university. And our IPL series provides this particular framework of engagement because it is one of the ways within which we, of course, converse with our multiple communities on topical issues of our time. Now, the issue of today can't be more topical as they come. And this forms part of our tradition of critical public intellectual engagement and, of course, scholarly contestations. In identifying possible topics for this particular lectures, we try to find issues of public interest and of contemporary relevance to our society that will advance what we stand for. The current global geopolitical situation is, of course, to state it very mildly, very depressing, but has brought forward new precarities and fragilities with regard to democracies internationally as well. There is a discernible trend towards the conservatization of politics, towards isolationism, towards exclusionary nationalisms, and of course an increasing way in which these particular global forces influence our international affairs. There are also some of those trends, of course, discernible in this African national context that provides for the basis on which social fragmentation is playing themselves out nowadays in such an intense form. And you can see it from our political discourse globally and nationally. It's being characterized by intolerance and misinformation and people driving particular agendas far removed from the democratic ethos that we should be aspiring to. The emphasis on multilateralism, global solidarity, and the principles of equity and social justice are being eclipsed slowly by self-interested agendas. And of course, you can only look at our own public institutions to see how those particular worrying trends are expressing themselves. There are also advances in equity and diversity that are being reversed and being rolled back as well. And it also seems that the question of global health have been pushed back into the back burner. And Jimmy, so we're looking forward to hear your analysis with regard to the current moment as far as the thematics of the lecture is concerned. And this is not good news for the global south, but of course it's not good news for the planet as a whole. So over and above this, more than 30 years into our hard-won democracy, as a country we've also faced our own set of domestic challenges, of which health is one of the more pressing ones. Of course, there are numerous others that are interlinked, crime, corruption, the capacity of the state, and the sluggish economy, all impact on the delivery of quality health services. Of course, we need to remind ourselves of what the Constitution says in this regard, especially with regard to the family of socio-economic rights in Section 27 of the Bill of Rights. Everyone has the right to have access to healthcare services, including reproductive healthcare, sufficient food and water, and social security, including, if they are unable to support themselves and their dependents, appropriate social assistance. The state must take reasonable legislative and other measures within its available resources to achieve the progression realization of each of these rights. No one may be refused emergency medical treatment. The South African Human Rights Commission periodically, of course, issue a particular kind of report on the progress that the society and the state is making with regard to the advancement of socio-economic rights. And of course, it doesn't paint a good picture of our country. In fact, some of the reports indicates that there was a progressive realization up to 2015, and that some of those progressive realizations are also in reverse mode. That is a very, very worrisome trend for our country. Now, these public lectures have become important platforms to re-energize a particular kind of citizenry that we would require to make our country work in an inclusive way. And so with regard to this particular lecture this afternoon, our aim is to provide a platform for us to collectively reflect on equity, evidence-based practice and the role of universities in transforming global and national health. Now, I cannot think of a more qualified and more appropriate team to lead us in the discussion this afternoon. Prof. Jimmy Volmink, as already mentioned, Prof. Busani Nkaweni, as already mentioned, and of course, Prof. Ntobeko Ntuse, as already mentioned. I wish to extend the university and the faculty's heartfelt appreciation to you for agreeing to participate in this important institutional public lecture. Program Director, and now I move towards conclusion, I would like to point out that the nature of the global and national health challenges facing us all make it imperative that we should develop productive collaborative partnerships with like-minded institutions such as the Wellcome Trust, the South African Medical Research Council, and of course the Eastern Cape Department of Health, the University of Johannesburg, and of course national departments as well. My apologies, because I have to disclose this. I need to leave somewhat earlier because of travels, but I look forward to the proceedings with much anticipation. I am sure the engagement this afternoon will become a significant thread that we weave into the tapestry that is the story of Nelson Mandela University in the service of society. I thank you, and please be most welcome.
Thank you so much, Acting VC, Professor Kiat. We really appreciate those words of welcome. I'm sure we feel welcome now. And in isiXhosa, we say, "Khululani bhatyi." And I'm looking at the school kids, don't take off your blazer. So we're not talking to you. And I would also like to welcome you here. It's always wonderful to see school children attending these public lectures as they learn so much from these engagements. Now, ladies and gentlemen, without further ado, I would like then to introduce Professor Busani Nkaweni. Busani Nkaweni has been the director of the Center for Public Policy and African Studies at the University of Johannesburg since August 2025. One of the center's flagship offerings is the PG DIP in Public Policy and African Studies, which draws students mainly from Parliament. From March 2020, he was Director General and Principal of the National School of Government in South Africa, which grew into a leading management development institute in Africa and a recognized think tank for public sector reforms and civil service professionalization. The NSG serves appointed and elected officials across South Africa and the broader African region, working with local and international university partners. He has since been appointed Distinguished Fellow of the NSG. Before this role, Nkaweni was Head of Policy and Research in the Presidency and served as Chief of Staff to multiple South African Deputy Presidents and the current President. Amongst key national programs he has coordinated are the National Minimum Wage Policy Setting, the 2010 Soccer World Cup, the National Anti-Poverty Strategy, the National AIDS Response, and the Framework Towards the Professionalization of the Public Sector, which is a key public sector reform strategy for the previous and the current administrations. His research interests span policy development and implementation, institutional design and strategy, public leadership, and economic governance. He has held academic affiliations as research associate at the University of the Chinese Academy of Social Sciences, where he is reading for a PhD in world economy, visiting professor at China Foreign Studies University, visiting professor at the Wits School of Governance, 2019 to 2025, visiting professor at Fudan University in 2024, and visiting scholar at Toronto Metropolitan University in 2015. He's also a fellow of the African Leadership Initiative, Aspen Global Leadership Network. Ngcaweni writes for leading newspapers in South Africa and Asia. His most recent of 11 edited books include Liberation Diaries, Volume 2, from Jacana Media in 2024, African Literature and Intellectual Histories, published by the HSRC Press in 2024 as well, and The Contested Idea of South Africa, published by Routledge in 2022. Jacana Media will publish his monograph, Frontiers of National and Regional Development, Rethinking Governance and Growth in the Global South. That will be published in November 2025. Without further ado, I would like to invite Professor Busani Ngcaweni to do his introductory remarks.
Thank you very much, firstly, to the leadership of the university for inviting me to join you today. I stand on all the protocols that have been mentioned. I had a number of choices today, so I changed my remarks 5 times. Under pressure from Prof. Zogi, she wanted something more poetic. I had to resist that. I could do something very academic, as the Prof mentioned. I spent 15 years in the presidency leading SANAC, so I could write many stories about the national AIDS response during that period, or I could just go academic. But I thought, since we are talking about the revolutionizing health, global health and change for equitable futures, maybe there is few anecdotes that one must share with you. Because we are living in an age where life-threatening pandemics move faster than diplomacy, and where geopolitics shape the lives, the lives of who lives and who dies long before pathogens have reached their peak. Speaking about revolution requires moral clarity and the courage to challenge manufactured consent and curated narratives. My perspective stems from direct exposure to health systems across more than 50 countries and 4 continents, where I have had the privilege of observing over the past 2 decades as a government official. I've traveled to work and learn in all of these 50+ countries, ranging from Singapore, China, United Kingdom, Saudi Arabia, Rwanda, Ethiopia, Vietnam, the Vatican, Russia, South Sudan, Finland, Mongolia, and several other countries. I've engaged policymakers, politicians, academics, street traders, and private sector leaders on broader public policy issues, and more specifically on healthcare, which I was curious about because of the responsibility I had in supporting the deputy president, 5 of them who were leading SANAC at the time. I've had the unfortunate experience of leaving dead colleagues behind in some of these countries. These colleagues passed away in these foreign lands because of fragile health systems. I'll have to go to their families and report, because as a most senior official in those trips, I'll have to go and report how your child has died and why we left him behind, because of a mosquito or any other ailment. These experiences taught me that the strongest health system are not defined by wealth, but by foresight, policy coherence, diligent execution, and national cohesion. They demonstrated to me that effective governance is a key determinant of a functioning health system. They also showed me that ideology matters less than institutional discipline. Furthermore, they demonstrated that what we often call radical reform in healthcare and in other spheres of public policy is merely long-delayed implementation of basics that others consider to be normal. In my observations, I've noted that sovereignty is not only declared by leaders, but also constructed through capabilities that protect life, regardless of the political system of a country. The will to live, the will to save lives and to improve labor productivity unites elites and ordinary citizens in many countries that I have mentioned and those that I have visited, from New Zealand to Tunisia. Across the world, I've encountered two competing paradigms of healthcare governance. The first one is a paradigm of inclusion. For an example, Singapore's health system is an integrated ecosystem guided by strategic foresight, disciplined planning, and constant data visibility. The key insight from Singapore is that inclusivity does not emerge from slogans, but from relentless institutional diligence and performance. These are at the level of service. Health workers in Singapore have to answer one single question: will you treat your mother the same way? In China, state capacity, manufacturing strength, surveillance system, and integrated public health institution operate as a national security infrastructure. They treat health not as a social expenditure, as many other countries do, but as a strategic capacity. I also saw it happen in countries like the UK, where despite enduring political turbulence, the principle of universal coverage remains a moral anchor that citizens uphold fiercely, despite successive hollowing out by conservative party administrations. I also saw the second and opposite paradigm, where health is treated as a commodity and access to healthcare depends on the patient's income. I witnessed such conditions where public sector has been hollowed out through budget cuts, deregulation, and structural adjustment. I observed this commodification of life in parts of the United States, where all the technological breakthroughs and Hollywood and everything that we know about coexist with catastrophic inequality. Whereas in their northern neighbor, that is in Canada, concerns for universal access preoccupy public policy. It is also prevalent in Latin America and many African countries where market logic has perverted primary healthcare systems, where communities are left to enjoy the pain of fragmented services. These are some of the observations that I have made as I moved around. And sometimes I ask myself whether in light of this, is the revolution possible in South Africa? But we must be honest here. Our system cannot remain suspended between aspiration and dependency, which has been the case. As I close, we are hosting the G20. I think it might be useful to cite a few observations that I have made to come here to navigate through all the G20 declarations and all the G8 declarations. That's because these are the structures in society, in the global community, that are led by people who have the most endowments. Although born as a financial stabilization platform, G20 has been drawn into health governance by force of reality. At the G20 summit in Pittsburgh in 2009, leaders declared our prosperity is interdependent. They were in fact referring to the markets. They were not talking about pandemics. Although later on, history will prove differently. In Brisbane in 2014, the G20 acknowledged that wheeled health systems threaten global economic security. In Osaka in 2019, health was reaffirmed as a driver of sustainable growth. In Riyadh in Saudi in 2020, during the pandemic, G20 leaders promised equitable access, but practice followed national interest. In Rome in 2021, leaders pronounced, no one is safe until everyone is safe. A moral imperative contradicted by the hoarding of life-saving resources. And our president, in a meeting in Paris 2 years ago, addressed the French president and others about this matter. In Bali in 2022, there was an attempt to strengthen the architecture, but there was an avoidance of redistribution. In New Delhi, in India in 2023, there was a promotion of regional manufacturing and local capability. In Brazil last year, there was a bold step taken of declaring health sovereignty, that it depends on decentralized production capacity. And in South Africa, as we know, one of the reasons why the President of the United States is not coming, we have declared that solidarity is key. I mean, as you know, he doesn't really like this word solidarity. But you cannot deal with issues of sovereignty without having strong foundations of building solidarity. In South Africa, we are talking about NHI. The G20 presidency is emphasizing accelerated universal health coverage through primary health care. Yet our democratic and domestic hesitance on NHI risks signaling inconsistency. We all know about the NHI Act, and of course, there are some who've taken it to court. We're at the crossroad, therefore, in closing. Either we implement NHI and close access and equity gaps, or lose the moral agency to lead society and political and as business elite. If we want to lead, as we all declare, we must embody what we advocate. Public sector capacity must be rebuilt, private sector participation must align with national priorities and objectives, stakeholder consultation must be exhaustive, leadership must be unwavering. We learned that it is possible through the COVID pandemic. I must declare at this stage, according to my own reading, that the notion that NHI is anti-private sector is actually an illusion. It is neither the government declaration, I haven't read it anywhere, to shut down private medical health care, nor can it be achieved under our constitution. There is space for coexistence, but in conditions of equity. We already have the nugget of proactive collaboration with the private sector. I can talk about the MRAN, I can talk about the Lena Kavapir, it's a difficult word. I can talk about digital innovation that is taking place and several other examples of collaboration. And if we learn from the management of the AIDS pandemic, understanding that the private sector, the civil society, organized labor, and the public sector, together with the international partners, can play a major role in reversing the tide. It is possible that we can actually use those lessons as South Africa and spread it to the global south in order to deal with the international health emergency that we are facing today. As you know, there are communities here in the Eastern Cape which were historically labor-sending centers. Those communities, there are people who are on life-saving ARV treatment and TB treatment that is supported by the private sector because there was a compact that emerged during that pandemic. It is possible, therefore, that we can use the same spirit to build a new compact, but we must be honest that the state must get its act in order, because the daily experience of our parents when they go to the public healthcare facilities may not match what is aspired for at a national level. And similarly, the private sector must also recognize that the health inequality or health inequity cannot be left in the state in which it is in. Thank you very much once again for inviting me to share. I could say a lot more, but I will end here today. Thank you very much.
Wow, thank you so much, Prof, for that very informative and provocative introductory remarks. Will you treat your mother the same? That's a big question, and I think it should be a takeaway from us. Commodification of life and the results to inequality. Most importantly, aligning our aspirations with our reality and embodying what we advocate. And that applies generally, in life. The state must get its act together. All right, ladies and gentlemen, without further ado, I am now going to invite Professor Zukiswa Zingela, the Executive Dean of the Faculty of Health Sciences, to introduce our keynote speaker.
Molweni. Exciting times, eh? So we already have had the protocol stated by our DVC, but I do want to acknowledge our university leadership, our acting vice-chancellor, Professor Andrea Kiet, our chair of council who's joined us online, Judge Nambita Dambuza, and our DVC, Dr. Moeng, who is our MC. I also, of course, acknowledge our key guests and VIPs, and most importantly, also our keynote speakers and our, learned academics who've come to share their thoughts with us. So, without further ado, I'm going to then introduce Dr. Jimmy Volmink. He's a colleague, and we've known each other for a while, so it was wonderful to be able to host his lovely presence here today. He serves as the Executive Director of Equity of Wellcome, where he champions the vision to create a healthier future for everyone through transformative research, leadership, and innovation for health equity. And of course, you can see that he was chosen deliberately if you look at the theme of today's public lecture. Jimmy holds prominent roles within health research. He's an emeritus professor of global health and also the former dean of the Faculty of Medicine and Health Sciences at Stellenbosch University. And throughout his career, his international contributions have included advancing evidence-based healthcare, addressing health and social inequalities, strengthening research capacity, and shaping leadership in health sciences education. Jimmy's impactful research has made significant global contributions to health policy and practice, particularly within the fields of tuberculosis, HIV and AIDS, cardiovascular disease interventions as well. He earned his medical degree from UCT, a Master of Public Health from Harvard University, and a Doctor of Philosophy in Epidemiology from the University of Oxford. And his work spans clinical research, health equity, global health governance, and lifelong education to equitable and inclusive research ecosystems. Jimmy's career is marked by a number of notable honors, including the Leverhulme Medal for Distinguished Contribution from the Liverpool School of Tropical Medicine, Fellow of the Royal College of Physicians, Edinburgh, member of the Academy of Sciences of South Africa, and as president or the President's Lifetime Achievement Award from the South African Medical Research Council. He has also received a Lifetime Chancellor's Award for the Sustained Excellence from Stellenbosch University. And he really, if you listen to all of his achievements, you can then tell that he has lived, but not only has he lived, he has worked hard throughout his life so far. He holds 2 honorary doctorates, a Doctor Honoris Causa from KU Leuven, Belgium, in recognition of his work to promote human dignity and his contribution to science and practice to improve health and well-being. He's also got a Doctor of Science Honoris Causa from McMaster University, Canada, for his pioneering work in evidence-based medicine. Let's give Jimmy a hand. Thank you.
Honorable Vice-Chancellor, esteemed guests, fellow speakers, friends, colleagues, and fellow changemakers, it's truly an honor to deliver this lecture on revolutionizing global health here at Nelson Mandela University, which is a space that embodies the pursuit of justice, transformation, and intellectual rigor. 25 years ago, while working at the Global Health Council in Washington, D.C., I was invited to the US State Department for a discussion titled, "Why Should the United States Fund Global Health?" The speakers offered 3 reasons. First, bugs travel. Addressing infectious diseases abroad helps prevent their arrival at US borders. Second, healthy populations abroad are good for the economy. They sustain global markets for American products and secure access to mineral resources. And third, global health investments reduce migration pressures by stabilizing vulnerable regions. Not once was solidarity, equity, or justice mentioned. That omission was telling. Today, we are witnessing the consequences of that logic. The recent wave of funding cuts from the US and other donors should not come as a surprise. It is the logical outcome of a system driven by national self-interest of wealthy countries. So global health is at a crossroads. And we must ask, what does it mean to truly revolutionize global health? Our response, yours, mine, and all the key actors invested in a healthier future for everyone, our response will set the vision for a healthier future in Africa. In 2025, global health funding dropped to a 15-year low. From a peak of $80 billion in 2021, it fell to under $40 billion. The US, by far the biggest funder, slashed its contributions by 67%. That's about $9 billion. Additionally, the UK is on a path to cut its ODA by 57% by 2027, compared to 2020. And France's budget for ODA was reduced by 39% between 2024 and 2025, a historic cut amounting to nearly 2.3 billion euros. These cuts have disrupted essential services, shuttered crucial research programs, and forced organizations from local to multilateral to close, downsize, or reimagine their missions. But this crisis is not just financial. It is structural. It is rooted in history. Think of this. Global health, as we know it today, evolved from tropical medicine, a field birthed during a period of imperial conquest and colonization. Tropical medicine focused on infectious disease control through vertical, single disease programs, while overlooking health systems, the social and economic drivers of health, and indigenous knowledge. This legacy has produced a chaotic, top-down, donor-driven model of global health that fails those most in need. Now let's be clear. It has been known for a very long time that the global health architecture, the systems, the institutions, the actors, the processes that shape how the world is organized to tackle health issues is simply not fit for purpose. Consider the following. First, fragmentation. Multilateral organizations such as the WHO, the World Bank, Global Health Initiatives, Gavi, the Global Fund, CEPI, national governments, philanthropic foundations such as the Gates and Wellcome, civil society, and academia operate in silos with overlapping mandates and poor coordination. This wastes resources and dilutes impact. Moving on to governance and funding. Health priorities are often determined in boardrooms far removed from the communities affected. This centralized decision-making tends to reflect the interests of donors and global institutions rather than the lived realities of local populations. Governance structures frequently lack meaningful representation from the global south, reinforcing power imbalances and limiting accountability. At the same time, private sector actors, such as pharmaceutical companies and technology firms, are playing an increasingly influential role in shaping global health agendas. Their involvement often steers priorities towards profitable solutions rather than comprehensive public health needs, raising concerns about transparency, conflicts of interest, and whether interventions truly align with long-term equity goals. Dependency. There is an over-reliance on a handful of major donors, which renders the system unstable. LMICs are often heavily dependent on the global north for disease outbreak monitoring, emergency response coordination, and the production of pharmaceuticals. Africa, for example, bears 25% of the global disease burden, but produces only 3% of its medicines. Over 70% of Africa's pharmaceuticals are imported. This dependency makes medicines expensive, supply chains fragile, and access to essential treatments unreliable. The recent COVID-19 pandemic dramatically revealed the extent of this vulnerability. And finally, we come to equity deficits. Health is a fundamental human right. Yet people most affected by health challenges are being left behind. Despite all the initiatives and institutions working to improve health and save lives, half the world, around 4.5 billion people, still do not have access to basic health services. Health systems remain underfunded, chaotic, inequitable, and inefficient. There is limited attention given to social determinants of health, such as clean water, sanitation, and housing. And all of this is compounded by a chronic underinvestment in health research and development. Let's be honest. A global health model built this way was always destined to fail. Real solutions to Africa's health challenges must be African-led. And here's the good news. We're not starting from scratch. For decades, momentum has been building for Africa to claim its health sovereignty. Across the continent, leaders have stepped forward. Among them, President Cyril Ramaphosa has played a pivotal role working through the African Union to champion a unified continental response to some of the most pressing global health challenges. Let's take a moment to look at some of these initiatives, and the previous speaker mentioned some of them already. I'll focus only on the ones that relate specifically to Africa. The Abuja Declaration, adopted by African heads of state in 2001, was a landmark commitment to prioritize health financing across the continent. It catalyzed the creation of the Africa CDC in 2017 and inspired the AU Roadmap to 2030, which calls for domestic resource mobilization, universal health coverage, and innovative financing, as well as greater transparency and accountability. In 2021, the Africa CDC and the African Union launched the new Public Health Order for Africa, a bold strategic framework designed to tackle the continent's health security challenges, especially in the wake of COVID-19, and to build resilient, sovereign, and equitable health systems. This framework, very briefly, rests on 5 key pillars. First, strong African public health institutions, calling on member states to support continental bodies like the Africa CDC and the African Medicines Agency, and to invest in capacity building across the region. Second, expanding manufacturing of vaccines, diagnostics, and therapeutics through collaboration among member states, removing trade and intellectual property barriers, and ensuring that global partners like Gavi commit to sourcing at least 30% of vaccines from Africa. Third, investment in our public health workforce and leadership, strengthening community health worker programs, and building capacity at every level. Fourth, increased domestic investment in health through innovative financing and public-private partnerships. And finally, respectful, action-oriented partnerships where global engagement aligns with Africa's priorities, magnifies Africa's voice, and supports infrastructure and manufacturing on the continent. These pillars represent a roadmap for Africa's health sovereignty and resilience. In 2023, the Lusaka Agenda took this vision further. It reminded us that strong health systems begin with strong primary health care, because that's where people's lives are touched first. It also called for something critical: financing health from within. If we want sustainability, we cannot rely on donors forever. We need to mobilize domestic resources and invest in our own future. The agenda also placed equity at the center, because progress means nothing if it leaves people behind. It urged us to bring coherence to global health initiatives so countries aren't overwhelmed by fragmented efforts, and it challenged us to build regional capacity for manufacturing and research, so Africa can produce its own vaccines and medicines and break free from dependency. Then in 2025, this year, came a defining moment: the launch of the Accra Initiative at the Africa Health Sovereignty Summit held in Ghana. This is not just another framework, it's a bold step towards reimagining global health governance and claiming Africa's rightful place in shaping the rules. The Accra Initiative sets out a clear vision: health as a strategic investment, as we've already heard, not just a social service. A transition from donor reliance to resilient, domestically financed systems, African leadership at the global table, and governance that is inclusive, accountable, and sustainable. To make this real, the initiative brings together powerful mechanisms: the Accra Compact, which articulates Africa's unified vision; Sustain, a platform which helps countries strengthen systems and build partnerships; a presidential high-level panel driving advocacy and reform; a joint ministerial task team aligning health and finance strategies; and a technical assistance mechanism to support early adopters and build capacity. The Abuja Declaration, the new public health order, the Lusaka Agenda, the Accra Initiative. Together, these efforts signal a turning point. We are moving from fragmentation to unity, from dependency to sovereignty. This is Africa shaping its own health future. However, we know many aspirations can and have remained unmet. While African governments pledged through the Abuja Declaration in 2001 to allocate at least 15% of their annual budgets to health, only 2 countries have met this target. The continental average remains at just 7.4%, highlighting a persistent gap between ambition and implementation. External aid dependence persists, compounded by limited fiscal space, low GDP, and competing priorities. Corruption, weak institutions, and political instability further impede progress. There's also no denying the impact of climate change, pandemics, and conflict. These challenges demand collective action and shared knowledge. So where do we go from here? How do we turn ambition into action? The truth is, there's no single solution. What we need is a comprehensive approach, one that breaks down structural barriers, strengthens systems, and creates space for innovation. And in this room, we have the ideas, the leadership, and the will to make it happen. First, we must work together to rethink how we finance health. That means everything from reforming tax systems, expanding the fiscal space, moving towards universal health coverage so families aren't burdened by out-of-pocket costs. And we need creativity, finding new ways to fund health through measures like sin taxes, diaspora bonds, local African philanthropy, and debt for health swaps. But financing isn't enough. We need governance that people trust, transparent budgeting, strong oversight, and zero tolerance for corruption. Communities must have a voice in planning because accountability begins at the grassroots level. We also need institutions that can lead. National public health institutes must be strengthened. The Africa CDC must be empowered to coordinate responses across borders. We must invest in research and development tailored to Africa's needs and harmonize regulation through the African Medicines Agency. Universities, the funding of higher education needs more attention. Data sovereignty matters too, because decisions should be driven by African data, analyzed and owned by African experts. And then let's not forget, the backbone of any health system is its workforce and infrastructure. We need to train, retain, and support health professionals. We need clinics, labs, and emergency systems that work. Digital health can help. It can help us leapfrog barriers. And local production of vaccines and medicines will also help break the cycle of dependency. Finally, partnerships, but not the old model of dependency. We need partnerships that respect Africa's priorities, elevates Africa's voice, and build South-to-South collaboration for shared progress. This is the path forward. It's ambitious, yes. And almost everything I've said, is a 20-year project. But it is possible. We have to start if we want to achieve this. The scale of the challenge is even greater as external funders pull back to focus on their own domestic priorities and defense. For African governments, this raises a tough question. How do we pursue an ambitious long-term agenda while facing cuts in funding, shortages of staff, gaps in critical data, and disruptions in essential medicines and supplies? It's hard for any country to drive strategic reform while firefighting a crisis. And in that firefighting, there's a real risk that short-term decisions could further deepen inequities. That's why it is imperative that choices made in this moment of crisis are guided not only by urgent needs, but by our long-term vision. Because if we compromise that vision now, we risk setting back progress for decades. I'd now like to share how the Wellcome Trust, as a funder, is contributing to global health reform. I joined Wellcome driven by a commitment to turn evidence into action for equity. I knew Wellcome worked globally to enable and invest in research across science and health. Yet I believed it could do more to advance health equity. And that's what drew me in. Even knowing I was trading sunny South Africa for London's famously gloomy weather. Now don't worry, I won't go into all the details of this next slide, as it's quite dense, so just relax. But I do want to use this to draw attention to a few points it illustrates. At Wellcome, we have made our position clear. Equity must be the foundation, not the afterthought of how we work together. Wellcome places equity at the heart of its strategy, embedding it across all aspects of its work. And the equity framework is our guide for delivering on our mission. It helps us center those most affected by health challenges, broaden who leads, who participates in, and who benefits from science. By enabling and investing in research, engaging diverse communities, and influencing systemic change, Wellcome aims to ensure that its efforts contribute to fairer opportunities, better health outcomes, and a more inclusive global research ecosystem. We believe real change is about shifting power, not just about sharing resources. This framework sets out our ambitions and the drivers of change we're committed to using. It connects Wellcome's mission, vision, and values to equity, both in how we work internally and in what we do externally. We believe equity isn't just a principle, it's a catalyst for better science and better health. It breaks down systemic barriers and brings in diverse insights and experiences that lead to real innovation. When equity is at the heart of research, every voice is valued, every perspective included, and that's what drives creativity and solutions that truly work. Equitable practices empower researchers with the tools and perspectives they need to tackle complex global challenges in ways that are nuanced and culturally relevant. They make research globally, they create space for collaboration across disciplines and cultures, reduce bias, and foster environments where innovation can thrive. When equity is at the core, research excellence becomes attainable, magnified by the diversity of ideas and partnerships that inclusive practices bring. That's why our strategic direction in low and middle income countries is unambiguous. Support local leadership, help strengthen local ecosystems, and amplify voices from the global south. Equity in research is a transformative force. It means recognizing the value of local knowledge and leadership. It means ensuring researchers in the global south are not just participants, they are leaders. It means building systems that are resilient, inclusive, and responsive to local needs. And as a funder, our role is to support that sort of leadership, not to overshadow it. That means letting go of old models and embracing new ones that empower regional institutions and local expertise. Let me take a few moments to mention a few examples to show what equity looks like in action. Wellcome has a long history of investments in strengthening research ecosystems in Africa and Asia, typically in partnership with UK-based institutions. This has resulted in improved infrastructure and the training of new generations of research leaders in various countries and regions. Ultimately, this has enabled leading-edge scientific contributions benefiting not only the global south, but also the rest of the world. But some of these old models of funding are colonial in nature and do not address underlying power asymmetries. However, change is happening. For example, we've been providing core funding to major international partner institutions in South Africa, Malawi, and Kenya, and I'm proud to say each of these are now led by a research leader from each of those countries. We have also begun to implement more equitable funding models, partnering with governments and other local funders, which gives more autonomy to in-country institutions in areas such as priority setting and funding decisions. For example, we have just agreed to the third phase of a partnership known as the India Alliance. This program is co-funded with the Indian government and supports biotechnology research across the whole of India. Then there is Deltas Africa. Since 2015, this program has trained more than 2,800 fellows across 57 African institutions and 18 international partners. Through Wellcome's partnership with the Science for Africa Foundation, based in Nairobi, which hosts Deltas Africa, funding decisions are made by those who truly understand the local context. Deltas uses a hub-and-spoke model that supports African-led research consortia, building leadership, responding to regional priorities, and nurturing the next generation of scientists. We also believe it's important to support South-to-South collaboration across the regions. The Africa-Asia Alliance for Clinical Trials, launched this year, is a multi-million-dollar initiative led by regional teams. And we've also recently funded the African Population Cohorts Consortium, a transformative effort that unites large-scale population cohorts across the continent. This will generate rich longitudinal data for research policy and societal impact, shifting the center of gravity for population science to Africa by Africans. Wellcome is committed to enabling African experts to lead funding decisions and research agendas, and we have ambitious goals to fund research in Africa even more. The era of donor-driven agendas must end. African countries are saying we want ownership, we want to lead, and they are, of course, right. Our role as a funder, as funders in general, is to support that ambition. As we've already mentioned, many countries are grappling with the sudden withdrawal of external funding, and the impact on health services and research has been immediate and severe. At Wellcome, we've stepped in where we can. We've provided significant emergency funding to institutions like the South African Medical Research Council, working alongside the Gates Foundation and the South African government to protect research capacity and keep long-term projects alive, projects that could lead to life-saving treatments. We've also partnered with Science Granting Council's initiative, which brings together 17 research councils across Africa to strengthen funding systems, share lessons, and support collaborative research. Through this initiative, African funders now have access to the most comprehensive open data on research funding flows to the continent, a critical step towards transparency and autonomy. But let's be clear. These efforts are just a drop in the ocean compared to what's needed to sustain global health. Finding better, more sustainable solutions starts with listening. Listening to the ideas and insights of people like yourselves, of everyone who cares about health equity. And to do that, we have to look beyond our own borders. And that's why Wellcome commissioned 5 bold proposals from thought leaders across Latin America and the Caribbean, Africa, Asia, and Pacific, Europe and North America, and the Middle East and Central Asia. These proposals are designed to reimagine the future of global health collaboration and funding, and to spark ambitious thinking about reform. And they are now driving regional dialogues led by partner organizations in each region, bringing together key actors to explore what's needed and how we can make it happen. The conversations will feed into a global convening in 2026 to build agreement on implementation pathways to reform. While coordinated by Wellcome, these efforts engage a wide range of government and non-governmental partners seeking to build political buy-in for reform and to ensure coherence and collective thinking across regions. This isn't about Wellcome imposing its vision. It's about creating space for a broader, more inclusive conversation about the future of global health. And we're connecting these efforts to major milestones, for example, the World Health Assembly, the UN General Assembly, and G20 meetings to build momentum for the reform that is so urgently needed. How else can funders come together around a shared vision and commitment to equity? The Lusaka Agenda and other recent agreements emphasize country-led development and multi-sectoral action. Funders need to align with these principles, and we must move beyond rhetoric. At Wellcome, we're partnering with Gates and with Novo Nordisk on a $300 million initiative focused on infectious diseases, climate, and nutrition research, placing LMICs at the center. It's a good start, but we need to go further. Funders must come together around a shared commitment to equity, not only supporting vertical programs that target one disease at a time for short-term gains, but also investing in health systems and tackling social determinants where impact takes longer to achieve. As funders, we need to step up, reduce competition, cut transaction costs, reduce the administrative burden on recipient countries, and coordinate efforts to maximize collective impact. We must move beyond short-term projects and ask ourselves, what do we want to see in 20 to 30 years from now? What kind of health and research ecosystem do we aspire to build for the generations to come? The world is changing, and global health delivery, research, and funding must change with it. Equity cannot be optional. It must be embedded in how we fund, how we partner, and how we measure success. Equitable collaboration is not just about fairness. It is also about effectiveness. It's about ensuring those most affected by health challenges are at the center of shaping solutions. It's about maximizing the benefits of science and building trust in science. The spirit of global agreements is clear. Country priorities must lead global development and research agendas. In this era of financial crisis and shifting geopolitics, every country and every funder must step up. Global health actors in the global north must support, not dominate these conversations. Together we must build capabilities, address inequities, and counter marginalization within and across populations. So let us commit not just to collaboration, but to equitable collaboration. Because when we center equity, we unlock the full potential of science to serve humanity. In closing, let me reiterate, global health will not be revolutionized in boardrooms. It will be transformed in communities when we design for everyone, everywhere. In a challenging geopolitical landscape with less funding for global health, now more than ever, governments, multilaterals, philanthropies, academia, civil society, and other partners must work together to catalyze a transformation that is not only equitable, but also effective and enduring. This demands, as we've already heard, courage, strategic investment, and regional partnership. The time for that change is now. So let's unite to build a global health system that reflects our highest ideals: fair, inclusive, effective, and resilient, so that every life, everywhere, counts. Thank you.
Thank you so much, Professor Volmink, for that keynote address. Welcome to our Vice Chancellor, Professor Sibongile Mutwa. She has joined us. We are glad, VC, that you traveled safely and you are with us. Science to serve humanity. Equity cannot be optional. The time for change is now. And reimagining global health investments that maximize collective impact. a healthier future in Africa need global engagement and partnerships that respect and align with Africa's priorities. Thank you, Prof, and thank you for showing us the examples that you illustrated. Colleagues, ladies and gentlemen, without any further ado, I would like the Director of the Medical School to introduce Prof. Ndobeko Ntusi, our respondent.
Just making sure we're plugging in on time. Thank you. Thank you, Program Director. And welcome and good afternoon to you all, and continued warm hugs to you. A special welcome to our Vice Chancellor, Professor Mutwa, and our respondent, Professor Ntusi, who should be online from the Medical Research Council offices in Cape Town. And you could just nod twice if you see him on the screen. I presume.
I'd like to confirm that I'm on, Rena.
Thank you, Ntobeko. Welcome, and it's a great privilege and a special pleasure to introduce Professor Ntusi. Professor Ntusi is President and Chief Executive Officer of our South African Medical Research Council. Professor Ntusi joined the MRC in July of 2024 from the University of Cape Town and Groote Schuur Hospital, where he was chair and head of the Department of Medicine. He is a distinguished and highly respected figure in the medical community as a key global opinion leader. His lifelong passion for evidence-based healthcare, health systems research, non-communicable disease multi-morbidity, and universal health coverage has positioned him as a trailblazer in medical research. Professor Ntusi is committed to advancing medical research and innovation, and is passionate about improving healthcare outcomes aligned with the MRC's mandate to advance the nation's health and quality of life. His leadership spans national, regional, and international platforms, where he has played a pivotal role in shaping academic agendas, postgraduate medical education standards, and advancing key national strategic priorities. His commitment to mentoring young professionals and supervising postgraduate students underscores his deep passion for nurturing the next generation of leaders, research leaders, and instilling hope for the future of research leadership. Professor Ntusi obtained his BSc honors degree in cellular and molecular biology from Haverford College in the US, and his MBCHB from the University of Cape Town. He is a qualified physician and cardiologist and holds numerous additional qualifications, including a DPhil in cardiovascular medicine from the University of Oxford in the UK, and an MD in cardiology from the University of Cape Town. Through his research partnership and collaborations, he has extensive experience in basic science, translational, and clinical research. He has also built strong links with colleagues in clinical medicine, immunology, molecular genetics, physics, biomedical engineering, and biomedical statistics. And he has shown a capacity for performance in scientific investigational teams, and is suited to being part of multidisciplinary and multi-center clinical studies. Professor Ntusi provides key scientific leadership globally through being on boards and scientific advisory committees on numerous organizations. It's my great pleasure and privilege to ask Professor Ntusi, Ndobeko Ntusi, to take on from here. Thank you, everyone.
Thank you very much, Dr. Mora, for that very warm and generous introductions. The program director, Dr. Mukimu Wen, members of the Nelson Mandela University Council, the Vice Chancellor, Professor Sibongile Mutwa, Deputy Vice Chancellor for Engagement and Transformation, Professor Andre Kiet, the Executive Dean of the Faculty of Health Sciences, Professor Zuki Zingela, the Director of the Medical School, Rino Mora, Provincial Health Leadership, my fellow speakers, Professor Dr. Busani Ngaweni, Director of the Center for Public Policy and African Studies at the University of Johannesburg, and my dear friend and brother, Professor Jimmy Volmink, Executive Director of Equity at the Wellcome Trust, members of staff at NMU, students of NMU, esteemed guests and dear friends of NMU. It's a singular pleasure and honor to be part of the program and to respond to the wonderful remarks you have just heard from Professor Jimmy Volmink. I thank Dr. Ngaweni for his framing remarks and congratulate Professor Volmink for the challenge he has laid for us. These public lectures are meant to educate, to inspire, to provoke and challenge, and to give hope. And I'm certain you will agree with me that Professor Volmink has achieved all of these noble aspirations in equal measure. Global health, as you have heard, is at a crossroads. The international financial architecture, financing policies, and actions have fallen short. Yet, the unfulfilled aspirations of people around the world have generated momentum for reform and created the opportunity for transformative change. Over the next few minutes, I wish to argue that the skewed structure and asymmetrical financial, epistemic, and power dynamics of global health in its current form are both unsustainable and untenable. Instead of its promise of equity and social justice, global health has been characterized by a demise of the global. Features of patriarchy, racism, white supremacy, and saviorism, neocolonialism, foreign gaze, and power asymmetry between high-income countries and low and middle-income countries, and the increasing lack of diversity, equity, and inclusion among global health practitioners and funders lie at the heart of what has gone wrong with global health. Therefore, reimagining global health requires that we address these intersecting systems of privilege and supremacy that continue to limit our ability to achieve equity and justice. Inequities are not only about the needs and concerns of the disadvantaged, but they are also about the systems that create and perpetuate these disadvantages. To borrow from the words of Seya Bimbola and Maduka Pai, privilege is complex and relational. The social structures that create disadvantage are exactly the same ones that create advantage from which some of us benefit. We need to recognize that the current structures in global health benefit high-income countries. Even the work or science is completed within the global majority. on whose back the careers, status, and prestige of many global health actors, scientists amongst them, rides. Being a physician, I shall respond to Prof. Volming's lecture by taking you through the clinical diagnostic process. I will start with the diagnosis in global health as I see it. I will describe the symptoms and signs that are pervasive and end with what I think the remedy needs to be for us to see the kind of health system we would all like to see. One underpinned by equity, justice, dignity, equality, and sustainability. And I will argue that of all the recommendations made by Professor Volming, partnerships are the most essential to driving the change we seek to see. As I do with all of my talks, I'm going to start by reading this history statement from my own organization, acknowledging our own complicity in the persisting health disparities in this country and committing our capacities and resources to the continued promotion of justice and dignity in health research in this country and beyond. I'd like you to note my disclosures in terms of funding for my research, but I declare that I have no conflicts of interest. So what is the diagnosis? In 2018, writing for the Lancet Commission on what the priorities should be for HIV in the era of the Sustainable Development Goals, my colleagues and I had this to say, that the Sustainable Development Goals sharply elevate global health and development aspirations, contemplating a world that is far more prosperous, far more secure, far more healthy, and far more equitable, where human rights and dignity are universally respected, and where human development unfolds in a manner that preserves the natural environment. In 2018, when we published this paper, we said that the 3 years that had passed since the Sustainable Development Goals were agreed had dimmed the prospects of achieving many of these laudable aims. By contrast with the international solidarity, the shared commitment and increased investments that characterize the era of the Millennium Development Goals, much of the world, we bemoaned, had since 2015 turned inward and towards authoritarianism, repression, a diminished role for civil society, and a policy of austerity for public investments and suspicion of international cooperation. We argued that as a result of civil conflicts that had yet to elicit an appropriate international response, more people than ever before have been forced from their homes and countries. And at a time when the fruits of scientific advances are so evident, denial in many quarters of the role of humankind in the degradation of our environment threatens the very health and well-being of our planet and its civilizations. We've gone on further to argue that in its current form, global health needs a radical reform and decolonization, which must be characterized by a constant and conscious effort to remove all forms of supremacy within all spaces of global health practice, within countries, between countries, and at the global level. Supremacy, I argue, is not restricted to white supremacy, as is common speak, or male domination, but rather it concerns what happens not only between people from high-income countries and low and middle-income countries, but also what happens between groups and individuals within high-income countries and within low and middle-income countries. Supremacy is there glaringly in how global health organizations operate, who runs them, where they are located, who holds the purse strings, who sets the agenda, and whose views, histories, and knowledge are taken seriously. Supremacy is seen in persisting disregard for local and indigenous knowledge, pretense of knowledge, refusal to learn from places and people too often deemed inferior, and failure to see that there are many ways of being and doing. Supremacy is there in persisting colonial and imperialist, European and otherwise attitudes, in stark and disguised racism, white supremacy, white saviorism, and displays of class, caste, religious, and ethnic superiority, in the acquiescing tolerance for extractive capitalism, extractive science, patriarchy, and much more. So, I wish to argue that the fundamental challenge right at the core of global health is a recession in solidarity, and that the global majority, a term I prefer to use rather than the more pejorative references to the global south and global north, which place the two in an unequal power dynamic. The global majority, where 85% of the world's population resides, despite their geographies being rich in biodiversity, culture, and innovation potential, and despite them being the source of knowledge generation, mostly in global health, though they benefit very little from this knowledge production and contribute very little to global R&D funding and activity, present us with a challenge. And this is the role of science in society. Science needs to be a unifier, a space where trust, evidence, and cooperation transcend politics, where the global majority is central to the discourse, co-shaping agendas, ethics, and futures. And as I've already heard from Professor Volmink, 5 countries, the United States, the United Kingdom, Germany, France, and Netherlands, make up almost 93% of international funding for global health. And all of these countries have this year announced significant reductions in their programs for overseas development assistance. Proportionally, many estimate conservatively that we may see a 20 to 50% reduction in the funding for global health over the next 2 to 5 years. In thinking about the diagnosis, I wish to say something about the political determinants of health. Many of you are familiar with the social, psychological, environmental, commercial, economic, and other determinants of health. This concept of political determinants of health, coined initially by Claire Bambra and colleagues from the University of Newcastle, where they state that health, like almost all other aspects of human life, is political in numerous ways. Because, like any other resource or commodity under a neoliberal economic system, some groups have more of it than others. And because its social determinants are amenable to political interventions. And because the right to a standard of living adequate for health and well-being is, or should be, an aspect of citizenship and a human right. Ultimately, they argue, health is political because power is constantly exercised over it as part of a wider economic, social, and political system. So moving away from the diagnosis that I've articulated, what are the symptoms and signs of illness in global health? Global health is inherently inequitable and is failing dismally on all measures of equity. The rise of nationalism, right-wing politics, and the erosion of democracy world over worsen the existing health inequities and health disparities. Many have argued that these power asymmetries need to shift from inequity to allyship. Global health continues to be a field where global North actors from high-income countries see themselves as leaders. And although the decolonizing global health movement has exposed the deep inequities inherent within the architecture of global health, this movement, prone to elite capture, faces several institutional barriers that prevent meaningful shifts in power. The lack of allyship in global health has recently manifested itself as vaccine apartheid, led by global North countries who hoarded vaccines for COVID-19, Mpox, and Ebola. And I argue that the current posturing by the US administration is another flagrant example of absent allyship. While diversity, equity, and inclusion are on the decline in global health, all efforts to correct this are increasingly seen as wokeism and reverse racism. Therefore, if we are to move forward, there needs to be a concerted effort to support the global majority in its leadership of global health. Importantly, funders from high-income countries, donors, and philanthropic organizations have enormous influence on all aspects of global health. They decide who leads organizations, who receives funding, what interventions are prioritized, and most high-income country universities and international non-governmental organizations are often unwilling to discuss the disproportionate influence of wealthy donors, fearing jeopardizing their own funding. Thinking about these symptoms and signs, what are some of the current global health practices we see? These include vaccine apartheid, a visa apartheid, the rise of nationalism and far-right politics and their influence on healthcare, further worsening the recession in global solidarity. Authorship practices and advancement opportunities that do not focus on impact, but rather on advancing the careers of scientists from high-income countries. So coming now to think about what the remedy should be, I think that partnerships are absolutely key in enabling a different system of multilateral integration and building new relations that are sustainable. It goes without saying that governments within the global majority need to invest in the health and health research of their own populations. And as the point has been made very eloquently by Professor Volming, we need to see more collaborations and networks between scientists in the global majority as a way of building communities of practice that encourage solidarity for sharing learnings and experience. And if governments fund the health and research of their own population, this moves us away from the current situation of perverse influence of donors and wealthy philanthropists, where funding decisions can be informed by local priorities. I want to touch briefly on the role of the academy in all of this. Much of global health is conducted through universities and similar research entities. It's a major problem that academics are incentivized to focus primarily on personal development, that is, tenure, awards, publications, impact factors, and grants, often at the expense of real impact. Universities and academic institutes involved in global health need to be held accountable for creating structures and processes that incentivize academics to be better allies, giving credit to high-income country and other privileged low- and middle-income country colleagues for supportive allyship work and power sharing, and be responsible and responsive decision makers on the ground, engaging with organic local processes and indigenous knowledge, engaging with local partners as leaders of the process of knowledge production and knowledge use. Ultimately, scientists, politicians, all of us in the global majority must identify priorities and define, fund, and implement strategies to deal with these. And all of this work needs to be underpinned by courageous leadership that is constantly seeking to address the intersecting systems of privilege and supremacy that hinder equity and justice. In a recent report, fellow scientists and I argued that if the world is serious about ending epidemics due to infections, the focus necessarily needs to be on Africa, a continent where annually we see 200 to 300 infectious disease outbreaks. And using HIV as an exemplar, we argued that there were 5 fundamental actions that need to be considered. These include healthcare investment and human resource development, collaboration between African institutions and regional leadership, of course, research and funding alignment with local needs, and neutralizing systemic inequities, and all of these underpinned by ethical leadership, robust governance, and accountability. In addition to partnership, I wish to argue strongly that all of us need to be involved in science diplomacy, which can be a catalytic tool as a bridge builder, a source of trust and evidence, a driver of equitable global governance, and an advocate for inclusion. And in doing this, being mindful of some of the key limitations, which include resetting trust not only in governments, but in science itself, increasing exclusion, resurgent nationalism, and weak multilateral integration. And so these partnerships can act as powerful bridges for co-creation of knowledge, for capacity building and strengthening, for resource sharing and policy alignment. And most importantly, these must not be partnerships of charity, but rather partnerships of equity, mutuality, and respect. And we need to recognize the role of reciprocity in these multilateral partnerships in order to build the kind of global health we would like to see, where these are premised on equity, utilize the power of leveraging, focusing on sustainable planning, ownership of science, and creation of platforms for shared learning and formal and informal connections. We also need to acknowledge the inextricable link between inequity and lack of innovation. I highlight on this slide a number of challenges related to this relationship, but wish to focus on the consequences of inequity suffocating innovation, resulting in underrepresentation in global scientific discourse, and how local solutions remain underdeveloped or unrecognized. And I think in this thinking around how partnerships can be a key driver of the change we seek to see, there are important lessons for Africa related to science, technology, and innovation leadership, the recognition of barriers, a need for unified voice for science as a driver of good in society, the creation of institutional arrangements that create safe spaces for inclusion, policy engagement, science diplomacy, and of course, knowledge translation. So in conclusion, I've argued that at the heart of what is wrong with global health is receding solidarity. I've also argued that across different types of rolling, cumulative global crisis and whole system catastrophic shocks, health inequities are exposed and amplified with evidence that people in contexts of precarity are more adversely affected by these events. And we need to critically consider the drivers of global interlinkages and the economic priorities driving them. Therefore, a reorientation of political priorities whereby societal and environmental goals take precedence over economic objectives is vital if we are to avoid health inequalities as an inevitable fallout of the current crisis. The future of global health depends, I wish to argue, on African countries gaining their agency and simultaneously on high-income countries being willing to yield some of their power to create more equitable global health partnerships. These partnerships, I've argued, are key to imagining a different reality of global health and for advancing policy engagement and knowledge translation. Ultimately, you and I, all of us in the global majority, must identify priorities and define, fund, and implement strategies to deal with our priorities. I thank you for your attention.
Thank you very much, Prof, for that response. It is highly appreciated. And thanks for taking us through a systematic response using that clinical analysis of diagnosis up to the remedies that we need to employ. Ladies and gentlemen, without further ado, we are now going to have our question and answer session. I would like to request the speakers to please come on stage. Do we have roving mics? No, for the people who are asking questions there. We do, okay. I will take one round of questions, colleagues and ladies and gentlemen. Are there any questions? It's 1, 2. Yes, I've noted. Oh, I've noted, is it Prof? Yes, ex-dean. Only 2 hands, all right, and then the third one, okay? If you can get to Prof here in the middle, yes. Thank you.
Thanks so much to the colleagues for those insightful presentations. Prof. Sandra Ridley, Head of Public Health. I totally agree with the colleagues that have indicated that there needs to be reform in terms of global health and the engagement with the global south. But perhaps we could hear more about how we, as the global south, engage with global health organizations. I think, it seems that we are, in a sense, happy to be seen as the junior partner and accept that. And how do we then change that? I think there's a change of mindset required on our part as well. So that was my first one. And the second point was around, at Nelson Mandela University, we've at our very early stages of developing our public health and global health programs. And I just wanted, and particularly from Prof. Volmink, any thoughts on how we reimagine training of public health and global health professionals so that we can, really achieve these changes in equity that we seek. Thank you.
All right, thanks, Prof. I'm sure you have heard that question. Can we get to the second one and then the third, and then you will be the fourth. Thank you.
Thank you to our illustrious speakers this afternoon. Health has always been on my mind for many, many years. And what bothers me, though, is that back about 30 years ago, the World Health Organization was using the slogan, Health for All, by the year 2000. It was a visionary statement, and we are still being visionary. And I just wondered, in terms of what is being said this afternoon, how those visions are really going to be implemented. I wish that Professor Volmink and our health minister could spend a weekend together. Maybe they are going to. Just to get the thoughts across, to infuse the ideas and the concepts. But it's also, I find, very difficult to understand because health is a basic commodity, as we've seen. It's become a commodity. It's become a saleable commodity. There's a divide here with the wealthy and the not so wealthy in terms of what health is able to be accessed. I see it almost daily with the public sector hospitals and what they can do for patients and what they cannot do for patients, and the cost of medicines these days. I think very wisely mentioned we should become more self-sufficient in developing our own medicines in this country. But my question really is this a new vision? Because we were saying this about 30 years ago. Thank you.
Thanks, Prof. If we can get the mic then to the gentleman.
Hello. Thank you, Chair, and thank you to the illustrious speakers. I've got a question. I'm an academic here at the university from the Faculty of Business, and I'm interested in health systems and international development, and practically from also what I've seen, having previously worked in international development. I'm particularly interested in partnerships, especially with global partners. And from my first-hand experience, I worked with the Gates Foundation, the Bill and Melinda Gates Foundation, as it was known then. And I was involved in resource mobilization and even attended meetings at the Gates Foundation itself in Seattle twice, and raising funding, $60 million for the first phase of the project, with an additional funding of $40 million which were met, and a brilliant project that was run in 5 countries in East Africa. And that project was in agribusiness. I worked with the Gates Foundation, not in health, but in the agribusiness section. And you can see that when donors give funding, which in that case was a project of $100 million, once the project has finished, normally countries don't have their own funding to carry on with those projects, and suddenly the project runs to an end. So the question then is, how can governments be able to, from their own resources, be able to prioritize essential services such as health? And from the first speaker, Professor Bassani, you said that the tremendous changes you've seen in China are actually driven by state intervention in critical services. We are sitting here in a situation where most African countries, South Africa included, the state is weak in terms of being able to fund these projects. How can the state be able to step in? And then on universal health, can we do universal health and put universities at the center of universal health? We have 20,000 or so students. This is the first phase where partnerships between government, private sector, and the university can be tested so that universities become centers of health systems where university-run hospitals run on universal health principles. Thank you.
Thank you very much. Let me be the only program director, so don't give the mic to anyone that I have not recognized. Thank you. Can I have the gentleman here in front, and then I will have you, sir.
Thank you very much. I'm Simas Mtota. I really appreciate the presentations from speakers and also in terms of respondents. Mostly key to it, to me, is a topic itself. Because if you actually look on the topic, it will say revolutionizing global health. Key to it is the definition. When I was looking at the definition of revolutionizing itself, is actually saying immediate, is calling for immediate transformative actions. So, which is very relevant, and this lecture, it has been long overdue, because if you look in terms of our Sustainable Development Goals, for 2030 now, we are only left with about four years. So, which means that these steps, they really need to be revolutionized in terms of ensuring. If you look on SDG 3, it will tell you about good health and well-being. I was very excited to hear that some of the recommendations that were actually coming up, Prof. Jimmy, in terms of, there were challenges in terms of leadership, and also challenges in terms of funding, challenges in terms of research. But now at a strategic level, when you look on these challenges are broad, so is there any way of prioritizing to say, because we do know that we don't have enough resources, as you were also indicating, some issues of funding. So those different challenges, is there any prioritization that we can say, let's focus on this one and do this one? Because my worry now, if we throw these different challenges, these broader challenges, we might not reach the goal in terms of 2030, SDG 3, good health for everyone.
Thank you, thank you. Can you just pass the mic to the front row? There's a... Thank you, Lynn.
Thank you very much, Prof, and good afternoon. Mine is just on two issues that were raised by Prof in terms of, one, the pathway as a recommendation going forward. Indeed, you mentioned 5 issues: health financing, leadership and governance, capacity. And you had even mentioned in an earlier slide that you are of the opinion that health workforce as well as infrastructure are the fundamental basis to see how we can improve. My direct question is, looking at where we stand now, would you say it's practically possible for us to try and get close to implementing the 5 simultaneously? And if not, which one would you think should come first? Because there is equally a concern that there has been an observation of inefficiencies, for instance. So there is always those reservations of saying, should we still pump in more money when we have not seen any improved efficiencies and capacity? So where would we go? On the other hand, there are those that are efficient, capacitated, who are also saying that we would do more, we would like to do more, but we are limited, that there is no funding. And that's one issue that I felt that I would appreciate your comment on. The last issue for me has got to do with, you made a mention that there is also issues remaining, global health 2026, global convening. And again, for me, is to understand, are we likely to have the same issues you raised of health workforce and infrastructure taking center stage as we go ahead? I think you had mentioned that as an organization, you had also tried to identify about 6 people that will pioneer these issues. Maybe I'm too biased because my portfolio is health workforce, so that's why my questions are on health workforce a lot. Thanks.
All right, thank you very much. That's the first round. Let us just give the speakers time to respond.
All right, no, thank you, colleagues, for the questions. So firstly, I must state this, that in South Africa, we quarrel over tender fraud, idle doctors and nurses, and broken health facilities. The culprits are known. In the countries I have mentioned, these culprits by now will be in the comfortable hands of their ancestors. But they move around us, flaunting wealth with grand entrances and all manner of public spectacles that we have witnessed. I want to argue that our arguments, as the 2 esteemed professors have said, as a middle-income country, we need to have this conversation by looking at 3 fundamental indicators, which will resolve even the contradictions with the private sector and the noise about whether or not we are optimally using resources. And these 3 fundamental indicators are child mortality, maternal health, and life expectancy. That is what we should be quarreling about, not those fellows that there are now commissions and omissions around them, because they shouldn't be amongst us in society. If we do that, looking at these 3 indicators and resolve contradictions between the state, the private sector, and other social partners, we will measure whether the system we have protects its people, not only at birth and in crisis, but across the span of their productive years. Because health-adjusted life expectancy completes this picture. I think it is possible, as colleagues have said, to evolve what we can call a global South consensus, which means, and I've never thought about it until those made an intervention in some of the questions, that in fact there are global South platforms that need to be used to place the health agenda squarely onto their, on their table, and it must be a priority. I was recounting how I read all the G20 outcomes and the G8 outcomes and what they've said about health, but to be honest with you, Program Director, I've not done that for BRICS, I've not done that for FOCAC, I've not done that for ASEAN, as well as other global South platforms. So what we need to do, therefore, which is useful that we've got colleagues from medical, health sciences here, politics, and so on, is to force that this agenda must also permeate in other global South structures as well, in the EU, BRICS, and everything else. That's why we can agree as a global South as to what is our contribution. Many academics say, this is not criticism, colleagues, please pardon me, and you saw the Ntosi made a declaration in his first slide. Many of us here are collaborating, and we're obsessed with collaborating with the global North, which created this type of dependency. That is why many of us are going through a crisis. I spent 15 years working on SANAC. The richest academics were those who were doing HIV and AIDS research, because they were dependent on these donors from the US, and now there's a kind of a crisis because that funding has been withdrawn. But there is an opportunity arising to collaborate more with Global South institutions. We need students from Brazil here studying public health, and students from here in Brazil and Chile and elsewhere studying public health, because there are things that have happened in those countries from which we can learn, just as much as they can learn. We need to study how Uganda manages Ebola so that it doesn't reach epidemic level, when other parts of the continent, they struggle with that, because there is a lot to learn. So in short, I'm arguing that we need a Global South consensus driven by collaboration at institutional level, amongst academic institutions and students, exchanges and research and so on. So that Prof. Ntusi and others here are not just writing only with people in the UK and so on the Lancet, but also that they are writing from people from Chile, from Guatemala and other countries as well, who are facing similar health emergencies. Thank you.
Thanks, Prof.
Thank
Volman?
you. I have to say, I don't remember all the questions that were asked, but let me just respond to a few. So the gentleman over there talked about Health for All. Health for All was a big declaration by the World Health Organization. It was supported by something called the Alma Ata Declaration, which was in 1978. And it was a commitment to improve health for all through primary health care, comprehensive primary health care. The very next year, that effort or initiative was undermined by a separate conference that was held in Bellagio, led by the United States, in which they deliberately undermined that approach of comprehensive primary health care, and they introduced something called selective primary health care, because they argued that it was too expensive to provide comprehensive health services. So the first thing to say is that I think that we are often, with all these declarations, they don't happen in a vacuum. There are forces, there are geopolitical factors that play into this. Some are supportive, some are opposed to, and we're seeing that pattern has persisted throughout history, really, and throughout as long as I can remember, certainly. So I think we need to be aware of that. The second is taking responsibility for ourselves. I agree with Professor Ntusi that we need partnerships, but equitable partnerships depend on everybody playing their part. And I think that, just in terms of how the Global South engages with the Global North, which seems to have a concentration of power, I think we have to put, skin in the game. We need to show that we are prepared to take responsibility for our people by investing in them. And we then draw on partners that can strengthen that can add to that. But we cannot go with a begging bowl and expect, people to be willing to help us. So I think there has to be a commitment. Now, which brings me to the third point, which is, in health we have a particular problem. Because health, unlike, and maybe my learned colleague here on my left can correct me on this, but in health, there has been a lot more sort of foreign aid available. So a lot more money coming from the Global South, Global North to support health. And in part, what has happened is that has set up a kind of a vicious circle, because many countries argue, well, if we can get money from the United States or the UK or European Union, why should we put money into health? We'll rather use it for something else. And that cannot be. That's not sustainable. You have to take responsibility. And the last thing I just want to say is that I do think that, you know, and that speaks to the point of how do you set up these programs. I think health is a global phenomenon. Health, you know, you cannot, if you want to address health, you can't just look within your borders. Because most of the health issues that we face today, whether you're talking about climate change and the health effects of that, whether you're talking about infectious diseases, whether you're talking about non-communicable diseases, which is driven through, you know, food policies and the import of, fast foods and other things from the global north very often. You know, all of these factors that affect your health are global. And so that's why we cannot work in a bubble here. We have to collaborate. And I think you're absolutely right that there is a need for us as a Global South, understanding our own issues, knowing what it is that we need, putting some, you know, skin in the game in terms of money. And by the way, I think that the Global South should never underestimate the expertise that they have. We have amazing expertise in Africa, in Asia, in Latin America. There are people that can make a huge contribution, not only to, you know, the Global South, but to the world. And we are seeing that in some areas. Professor Ntusi is a great example of that. So I just think it's time to stand up and say, okay, we're going to do this together. We're not going to be so dependent on others to help us, but we're going to share that burden and that responsibility. And we can do, and different countries, as you said, you know, we're not all at the same level of ability to make that contribution. And so we actually, as Wellcome, we're thinking, you know, we've been working in Africa, we've been working in Southeast Asia, and we've been working in South Asia. Now, if you look at what's happening in terms of growth in South Asia and Southeast Asia, it's at a much faster rate than Africa. So we're thinking that maybe we should have a different strategy in the different regions and leverage more funding maybe in Southeast Asia and South Asia than we do in Africa. So we're thinking through how we do that. But ultimately, I think it's really important for all of us to understand that we need to be part of the solution, and we cannot sit back and wait for others to do the job for us.
Oh, thank you very much, Prof. Prof. Ntusi, your response?
Thank you. So I think a lot of the questions have been addressed. Perhaps I can comment on the two questions by Professor Sahendra Modley on how should scientists in the global majority show up in partnerships, and two, how should we be reimagining the training of public health specialists in this country. In 2021, colleagues of mine at the University of Cape Town and I conducted a large study where we interviewed scientists around the world to understand what are the components of equitable partnerships. And there were sort of 10 key themes that emerged out of that consultative process. And the first of these was around partnership, and exactly the point that Professor Volming just made, that countries in the global majority need to demonstrate skin in the game. And my strong view is that these countries may be considered low or middle income, but they are by no means poor when you look at the budgets that go towards their militaries or the budgets that support the activities of misappropriation and corruption annually. These are substantial. And the challenge is really around leadership and political will to prioritize health and to understand its value as a primary driver of human capital development and generation of a knowledge economy. So funding was one really critical aspect. The other was capacity development, clarity on authorship practices, clarity on sample ownership, and a priori research agreements, ensuring that the research addresses local priorities, and starting with an acknowledgement of the existing inequalities, but also a recognition of the strengths of partners and what they bring to these partnerships. But two things were key. One was the fundamental essence of trust in enabling these relationships. And then secondly, communication, having an effective and efficient strategy for how one communicates. And so I think those elements, Sahendra, ring true today in how partners from low and middle income countries should be showing up in these global health partnerships. And we hope in thinking about these issues as one forges new partnerships, you can also avoid many of the traps that we've seen many fall into. In terms of the approach to training public health and global health specialists for the future, I think there are a number of critical elements to the curricula. The first is a focus on decolonization of global health, looking at the role of indigenous knowledge systems, but more critically at how knowledge is generated, how knowledge is curated, and how knowledge is shared and translated. And being able to reevaluate and restructure global health programs to be able to dismantle many of the structural inequities that I spoke about in my remarks earlier. And then the second core element of training is that there needs to be an intentional effort to build local human resources and capacity enhancement. 3, a deliberate focus on how education can advance health systems strengthening, enhancing data science skills. We need data as a key driver of many of our goals in global health. And where no data exists, we are limited and unable to plan appropriate interventions or policies. But these data need to be associated with clear governance platforms for ownership and for sovereignty. And a key focus on occupational and environmental health, but also thinking about how the education for public health specialists focuses on leadership development and mentorship. So I would say those are some of the key attributes one would like to see feature more prominently in the education and training of the kind of public health specialists we'd like to see in the future. Thank you.
All right, thank you very much, Prof. Ladies and gentlemen, unfortunately, we cannot take another round of questions. I am now going to ask, and thank you so much, Profs, for the response. Thank you. I'm going to call Professor Zukiswa Zingela for the vote of thanks.
Wow, that was quite something, wasn't it? And my job is so nice and easy because our speakers brought it and then some. And if one then, just reflects on all the activities and intellectual pearls of wisdom that we got today, I literally only have a few words to say thank you and to also say our appreciation, because not only has it enriched us in terms of our understanding of what needs to happen in the world full of challenges, where we have crisis upon crisis in our health systems, and yet we heard today that we are not helpless. We heard today that we can aim for tangible results. And all three of our speakers reiterated the same message. So please allow me to thank, first of all, Professor Ntobeko Ntusi, only because he is online, so I'm starting with him. And unfortunately, because you are online, Professor Ntobeko Ntusi, I cannot pass this gift on to you, but I promise you, it is still flying from my heart into your hands, even if you're sitting in Cape Town. So thank you to you. And then without further ado, I would then like to proceed to thank our speakers, and luckily they are in front of me, so I can hand over gifts. Starting with Professor Busani Maweli, and to say a big thank you to Prof. Busani. Appreciate it. And then Professor Jimmy Volmonk as well. Thank you so much.
You were a great audience. Thank you so much for your questions and your attention. Now we're going to have a photo opportunity, after which we can have some refreshments in the foyer. Oh, and Professor Ngela still needs to bulela some more people.
Yes. Thank you. I'm sorry, I had to jump for a photo op. And I am aware that we are running out of time, so I want to thank my DVC for reminding us. So a quick one. First of all, to our university leadership, this would not have been possible without you. That includes our Chair of Council, Judge Nambita Dambuza, our Vice Chancellor, thank you, VC. It's wonderful to see you in the front row. Professor Sibongile Mutwa, our DVC of Transformation and Engagement, Professor Andre Kiet, our DVC of Learning and Teaching, Dr. Mukimu Weng, the whole Faculty of Health Sciences Executive, in the form of our ex or previous Deputy Dean, Professor Daliena van Rooyen. And in addition, we also want to, oh, there she is, wonderful. There's Professor van Rooyen, so thank you. And we also want to thank our current Deputy Dean and newest Dean, Deputy Dean, Professor Zoleka Soji, Director Medical School, Reno, and our other directors, Acting Director, Professor Nanette Smith, and Professor Paula Melariri, and then lastly, our Director of Learning and Teaching, Professor Annelien Kiet. Then in addition, the support in my office has been incredible in the form of Annelien Mansdorp, Ratani Nemuramba, Susan Dili, Marika Julie. I sound like I'm at the Oscars, right? Marketing and communication team, you were excellent, all of you. Without you, we would not have been able to do this. Our video and media personnel and support, you were great. And also, of course, our Faculty of Health Sciences, IT and Communication, wonderful work. Our ushers, specifically, I'm going to name them, Hakin Dalamo, Shifiwa Habara, Sandra Ledwaba, and Selwane Matibe. And then lastly, our institutional support in the form of Ellen Zinn, who's sitting right there, Ms. Buiswa Scott, Mr. Lubabalo Sama, and then all colleagues who shared their wisdom, colleagues from Faculty of Law, because of your experience, colleagues from Faculty of Humanities as well, because of your experience. We learned, and hopefully we'll be able to do this one more time with your help. Thank you very much, everybody, and you were a great audience. Thank you.